So the first topic, obviously, this everything is very important. So you need to read it. A lot of MCQs comes from nausea, vomiting, hyperemesis gravidarum, and prenatal visits. So you need to know because these everything you have to memorize by heart. A lot of things like when to do first ultrasound, when to repeat the ultrasound, when to do fetus anomaly ultrasound. So those kind of questions are used to ask in MCQs, and I have seen a couple of questions in different Q banks, like in uworld, in ACE Q bank, and like in everywhere. So you have to remember each and every visit, when to ask, when to come, and when to repeat the ultrasound, and the one of the thing, the symphysis fundal height. So you need to remember when it comes to umbilicus, fundus as umbilicus, which week is it? 20 week. So I have seen a couple of MCQs in different Q banks where they were asking about the fundus height according to they tell you that height is up to umbilicus, above umbilicus, or low below umbilicus, and then you remember the weeks. So what you need to do right now, if you have Toronto notes with you, or if you are using PDF whatsoever, mark it down, so when you read it next time, or when you are going to read it, you know which is important. You have to pay more focus on that. So I'm just going to be highlighting a few points here and there. So those are like I have seen those MCQs here and there. So it's very important. So this table is very important. Okay, so next, moving on from here, this is the first topic that we are going to cover. It's on page number 7, prenatal screening and the diagnostic test. So obviously you need to know screening test, what we need to do, how we need to do. So before doing the screening, what we need to do is we need to counsel, and we need to start from the consent. So we cannot directly jump and start the first we need to do is start the consent, and you need to ask the patient. The permission is very, very important. You cannot just jump directly into it. You have to tell the patient about the procedure. You need to ask about the consent, and then you can start with the diagnosis. So now let's start with that disease. Disease is basically thalassemia, sickle cell, cystic fibrosis, Tay-Sachs, and febrile X syndrome. So they're not mostly asked about these kind of directly, but you need to know like what kind of screening tests to be done. Like if a thalassemia patient comes, so you need to know CBC is done, HB electrophoresis, HPLC, and these kind of things. So you need to memorize by the heart. So you need to know every single thing, which screening is done in which disease. Population thing is not that important. Then comes here, this table. This is one of the very, very, very important table of the obstetrics, because a lot of things are focused on this point. So this table is very, very important. If anyone who is unmute, please kindly mute yourself. Just a second. Okay. So then comes the okay. So then comes the gestational age. What is done when a woman comes for the first time at the age of like 8 or 12 week? What is done? Everything. Dating, pap smear, chlamydia, gonorrhea. Obviously, you are not going to do it right away. You need to tell the patient that I'm going to do STI screening. Then you do chlamydia and gonorrhea. Sometimes they ask directly, if you are going to do STI screening, what are you going to do first? So they're asking in a way that either you are going to directly jump, or either you are going to ask for the consent or counseling. So I typically and preferably say you need to know the choice of the words, which words you are going to write in the answer. Sometimes in CDM you have to write down the answers, so you need to know what words you are writing. Sometimes you are writing a big paragraph and that doesn't make any sense. Writing down counseling, writing down consent, these words give you marks instead of writing, oh, I'm going to ask for the permission and blah blah blah. That doesn't make any like good sentence, doesn't give good impression, because words carry a lot of weightage. So you need to know what words you are choosing. So then comes at 8 to 12. So you have to remember everything from here. Then comes more than 10. You need to do NIPT, basically non-invasive. I'm not sure what is P. Then this test. Then what you need to do is basically you measure cell-free fetal DNA in the maternal circulation. You take from the maternal circulation and you do cell-free fetal DNA. So what is the first diagnostic test that is earlier done? This is very important. So the first diagnostic test that is done earlier in the pregnancy is basically CVS, chronic villus sampling. This is the diagnostic test. This is done at 10 to 12 weeks. So you need to know these weeks, very, very important. So you need to know each and every week, each and every test, at what weeks they are supposed to be done. So it is very important because these are asked directly like that. If a woman is coming at 10 to 12 weeks, what test are you going to do? You are going to do CVS. If a woman is coming at 10 to 11, what are you going to do? If she is coming for FTS, which week you are need to do? So they can ask in the alternative way. Either you ask about age, either they ask about investigation. So you need to know both ways. Then comes then 11 to 14, you do FTS. Then at 11 to 14, you do knuckle translucency, ultrasound to rule out Down syndrome, to rule out all those like open neural tube defect and everything. So what you need to measure is knuckle translucency, beta ACG, PAP, placenta, growth factor, MMSAFP. Then in 15 to 16, what you do is amniocentesis, which is also a diagnostic test. So 2 diagnostic tests is done. What is one? Which one? CVS. And what is the other one? Amniocentesis. Which one is preferable? Amniocentesis. Which one is done first? CVS. Amniocentesis is covered, both are not covered by government. So you have to pay private. If somebody wants to do private, go for it. If somebody cannot afford it, you can hook up with some social workers and stuff like that. So then comes is 15 to 20, IPS is done, which is obviously the same, MSA, PF, alpha fetoprotein, then beta HCG, unconjugated estrogen, inhibin A. Then in 15 to 20, maternal serum screening, measure maternal serum alpha fetoprotein, beta HCG, unconjugated estrogen, inhibin A. Then 18 to 20, you need to check for the fetal movement. So sometimes they ask about at which week you will ask about the fetal movement. So what we need to start is basically 18 to 20. Then at 24 to 28, gestational diabetes. It's very important. It is asked in many Q banks that a woman is coming, you need to check the diabetes. When are you going to do it? So it's 24 to 28 week. So at 28 week, repeat CBC, ferritin, and RH factor. Then 35 RH factor is given at which week? 28 week. 35 to 37 GBS screening is done, and it's at postpartum. You need to check about the contraceptives, menses, breastfeeding, depression, mental health, sport, breast exam, pelvic exam, pap smear, and wound assessment, and all of these things, because she's coming after the delivery. Now, what comes next is basically on the side. Routine T2 ultrasound at 18 to 20 week helps what? Number of fetus, gestational age, location of placenta, and fetal anomalies. So at the diagnosis of the increased maternal serum alpha fetoprotein, what you can check, maybe it is increased due to incorrect gestational age, maybe it's more than that, and you were checking because it's coming high because it was high. Because the age was different than the maternal serum alpha fetoprotein. More than one fetus, maybe there were 2 fetuses, that's why the maternal serum alpha fetoprotein is high. Fetal loss, open neural tube defect, and abdominal wall defect. So sometimes they ask about, okay, why if the woman or whatsoever, you have done the test and maternal serum alpha fetoprotein is high, and now they're giving you different diagnosis down, and they were asking about what could it be. Maybe you need to know by heart that, if you know directly that maternal serum alpha protein high is in, it's high in open neural tube defect, you don't need to read the other whatever lines, and you don't need to get confused with whatever it's written. It is increased in what? Open neural tube defect. You don't have to waste extra minute on that. In that MCQs, you can save your time. So you need to know in these kind of things. Sometimes they're just giving you directly the lines. So you need to know, okay, this is the answer. Now I don't have to spend enough time, because if your knowledge is not good enough, MCQs, or you keep on thinking, and then it's not going to go anyway. Then amphalocele, maybe they give you the scenario, and then they are giving you in the scenario that maternal serum alpha protein and everything is given. You are mixing it, amphalocele and the gastroschiasis, that is also one of the disease. But you need to know that maternal serum alpha protein is high in amphalocele, but not in gastroschiasis, right? So if you know this kind of difference, you might be able to differentiate it right away. Oh yeah, this is it. There you go, right? So this is very important. You need to know, okay, which one is present in which one. Okay, then comes the ultrasound screening. Dating ultrasound is done on 8 to 12, and then crown lump length is done, and EDD should be used on the T1 ultrasound if available, 11 to 14 week ultrasound for the anti. Increase the amount of the fluid behind the neck of the fetus, and what happens with knuckle translucency, we check the fluid behind the neck and check it with trisomy 21. Knuckle translucency is assessed for the 50S and IPS part 1, 18 to 20 growth and anatomy. So if they're asked about when are you going to do an anomaly ultrasound, So you're going to do at 18 to 20. Subsequent ultrasound performed medically indicated, like you are going to do for the placenta previa. You might need, if the patient, if the baby is restricted growth, so you need to do these ultrasound again and again. So these are the basic ones. So if needed, you can repeat again and again. Then comes the non-invasive prenatal testing. That was I was talking about, NIPT. Then those ones, if in that you are going to take the maternal blood, you are not going to do anything with the baby. You are going to do the maternal blood and check the cell-free fetal DNA. In that, which is done at 10 week onwards and requires dating ultrasound for accuracy. Advantages is basically you can check trisomy 21, trisomy 18, Turner syndrome, DiGeorge syndrome, Cre-Do, Chad syndrome, Prader-Willi, Angelman. So these kind of scenarios might come, like what kind of you need to rule out in trisomy 21, what kind of test you are going to do, NIPT, right? So that is given in right away in the scenario, and then you can just write down the answer. Yeah, this is the it, and then I'm moving on to the next one. Then disadvantages, does not screen for open neurative defect. If they ask about what is the disadvantages, one of the biggest disadvantages is this cannot tell about, because open neurative defect cannot be ruled out in NIPT. And then it is not covered by the provincial, as I already told you. Health insurance doesn't cover it, so you have to pay private. So this is one of the very biggest disadvantages, because a lot of people doesn't want pay. So need to confirm with the invasive. Then you, if you are going to do NIPT, then you have to confirm what are the diagnostic tests that I already mentioned, CVS and amniocentesis. Still you need to do those. If you are doing NIPT and you find something that maybe it is trisomy 21 or trisomy 18, you cannot surely say, yeah, this is trisomy 21. You still need to do diagnostic test. And on the basis of diagnostic test, you will say, yeah, this is trisomy 21. I hope that makes sense. This is very important to get a little bit of overview about this one. So when you read it again, it will be very easy for you. That's why I'm telling you this health insurance and invasive disadvantages is very important, and disadvantages is very important as well. So you get to understand why I'm not choosing this and why I'm choosing this answer. Does not test for all aneuploidies, does not gives no result in 1 to 5%, like insufficient fetal fraction, more common in elevated BMI. Then this is a comparison of EFTS, MMS, and IPS. What I remember in this one, risk assessment, right? You need to know this one is used to test for the Down syndrome. This one is trisomy 21. This one is used for open neurative defect, trisomy 21, 18. And what happened here is this is increased anti-PB, beta C anti is basically knuckle translucent CPAP A. Then comes the anti is increased, and this and that. You have to remember it just like that. So there is no shortcut for that. I tried to find a lot of shortcuts, but it's not working. You can just compare with each other and you get to know, yeah, this one is different from this one is different in this way, this one is different from this way. So if you find it there is a little difference, you will easily differentiate between it. IPS is important because there's a knuckle translucency that is present. 11 to 14 fetal screening blood you can do, and 15 to 20 maternal serum screening. So you can do all of these to check out O and TD, trisomy and trisomy 18. Sometimes they're asked in scenarios, and sometimes because if your concept is clear, you don't need to memorize it. That's what I'm saying. You need to make a little concept about it. So you get to make, oh yeah, this is what it is. It's going to be like that. Okay, so it's very important when you are reading it next time, make a concept, make a know, oh, this is going to be increased in this one, and this is going to be decreased in this one. That's how I memorize it, and I would definitely recommend you to do it the same, because you cannot just do like memorization again and again. You will eventually mix it up. So that's why make little concept. This will be increased in this one, this will be increased in this one. That will help you a lot. I have seen like 1 or 2 MCQs in different tubings, but not eventually a lot of MCQs about it. But I have seen couple of MCQs about it in uworld. So if you're using the uworld, you will see a lot of MCQs about this. Diagnostic test, amniocentesis, chronic villus sampling. Indication is basically more than 35, abnormal prenatal test screening, IPS, EFTS, MSS, and IPT. Past history, family history, chromosomal anomaly of the genetic test, and known carrier of the genetic disorder or the balance translocation, consanguinity, more than 3 spontaneous abortions, amniocentesis. Okay, so now comes the 2 diagnostic tests, amniocentesis and chronic villus sampling. Amniocentesis, ultrasound guided transabdominal extraction of the amniotic fluid. With the name of amniocentesis, you get to know, yeah, you are taking amniotic fluid at the time of what? At 15 weeks. What are the indications? What are you going to do is you're going to check for the genetic and chromosomal anomalies, like I already mentioned. What are you going to check for the NIPT? Like NIPT comes positive. Now what are you going to do is amniocentesis, either CVS. So now you have to choose why amniocentesis and why not CVS. So if you know the advantages and disadvantages, on the basis of that, you can choose. We are going to go with the amniocentesis and CVS. So amniocentesis is preferable over the chronic villus sampling. Now comes the advantages. Let's see the advantages. Advantages because it can tell you open neural tube defect. This is very, very important. This shows open neural tube defect, but chronic villus sampling does not screen for open neural tube defect. That's why we prefer amniocentesis, because when we are doing amniocentesis, we can get to know one more disease, and it's very 96% accurate, right? So we can go for it. But what comes at disadvantages? It doesn't have like a disadvantages very much, but maybe pregnancy loss, local experience. But those people who are not experienced may cause some problem with that. And results take like 18, 14. It is like a long, if somebody is looking for a test, I want to be done it like in 5-10 days. Which one I choose? Chronic villus sampling, because it takes like within 48 hours. So the answer comes in 48 hours if it's positive or negative. But on the same time, if it's going to take like 14 to 28 days, right? So it's going to be amniocentesis. If that mother is in a hurry, she wants it right away, the results. So what I'm going to choose is chronic villus sampling. But if she says it's okay, take as much as time, but I want the good results, the best results, what I'm going to choose is amniocentesis. So it is very important you know the advantages and disadvantages. On the basis of that, you are going to choose your answer. So it's very important. So then comes is compared to CVS, amniocentesis has a higher accuracy, as I already told you. Which one is preferred? Amniocentesis. But if somebody wants a short time, then go for chronic villus sampling. Then comes the risk factors for the neurotube defects. Then comes what is those risk factors? Gray, maybe genetic, race, Americans, maternal chronic disease, and maternal use of anti-epileptic drugs. These cause an open neurotube defect. Sometimes they asked about anti-epileptic. I have seen a couple of questions where they were given, the answer was anti-epileptic, diabetes mellitus, and African. So I have seen these three in uworld, in ACE Bank, in Canada Q Bank. These three were asked a lot. What are the causes of the neurotube defect? I'm just mentioning it because I have seen it somewhere, so that's why. Okay. Then comes isoimmunization screening. Which one is important in this one? Is basically prophylaxis. I know the screening and investigation, everything is important, but what asked mostly, I have seen like a lot of questions from prophylaxis, so I'm going to cover this one. Exogenous Rh IgG binds to the Rh antigen of the fetal cells and prevents them from the contacting maternal immunoglobulin. That's why we are giving it at what? 28 weeks, then within 72 hours of the birth. So you need to know when you are going to give it. So, and any invasive procedure like CVS, amniocentesis, you are going to give it as a part of the management of the ectopic pregnancy, miscarriages, therapeutic abortion, antepartum hemorrhage, and with the trauma. ROGAM and then clear Batke test is done, can be used to measure the amount of the quality of the fetal blood. Then comes Rh negative and AB positive, screen positive, follow mother with a serial monthly AB titers throughout pregnancy, ultrasound, serial amniocentesis as needed, because ROGAM has no benefit as the B cell sensitized antibody already present in circulation. So already you need to know when to give the prophylaxis. So you need to know these ones. Then investigation, what are the investigation? Either Coombs test and clear Batke test, and ultrasound for the fetal hydrops. So if fetal hydrops fetalis has already present, what are we going to do? And you need to know what is fetal hydrops. Fetal hydrops is basically if the edema is present in 2 fetal compartments, then it says fetal hydrops. Otherwise, it is not. If somebody is presenting with an edema in 1 compartment, like having edema in the belly, it doesn't mean that she's having fetal hydrops. It has to be in 2 compartments, either in heart or anywhere. So it is basically. So and then it comes in the erythroblastis fetalis. It could be called lead to 2 complications: hydrops fetalis and erythroblastis fetalis. Then the treatment is falling biliary pigment, intrauterine transfusion between 18 to 35 with the O negative packed RBCs, and delivery as soon as possible. So following like 35 weeks. So what, as I already said, that if somebody already developed fetal, so what was that? Hydrops fetalis, what is the treatment? So I want you to write down the answer in the group. So we will discuss from there that hydrops fetalis treatment is very important because it's not written here. Okay, so the next topic that we are going to cover is antepartum hemorrhage. I'm going to go there directly. Okay, antepartum hemorrhage is one of the very important topic. You need to know the general treatment of it. You need to know the 1-by-1 treatment of it. So first we are going to see the general treatment. Then we go for placenta previa, placental abruption, then vasa previa. Then comes the antepartum hemorrhage. It may be that you need to know the differential diagnosis, because if somebody asks you the giving the scenario of the placenta previa, and they're asking to write down 2 or 3 differential diagnoses. As I already mentioned, if you don't know the differential diagnosis, you cannot write down 2 or 3 answers, right? So you need to know what are the differential diagnoses of each and every single disease you go through, not just ops, not just gynae, every single disease you go through, you need to know the differential diagnosis. At that basis, you can write down the correct answer. Then comes the differential diagnosis. What are the differential diagnoses? Bloody show, placenta previa, placental abruption, vasa previa, cervical lesions, uterine rupture, then other are basically bleeding from the bladder or the maybe bleeding from anywhere of the body part, abnormal coagulation, not another body part, but maybe from the systems. Comparison of the placenta previa and abruptio placenta. Placenta previa is basically when the placenta is present in the anterior partially completely over the internal cervical os, which is basically idiopathic. 0.5 to 0.8% of all pregnancies. Risk factors are history of placenta previa, multiparity. You need to know the risk factors. Sometimes they give you the risk factors and give you a little bit of scenario that she's presenting with the bleeding. So if you know the risk factors, you can tell, yeah, this is placenta previa. So multiparity, increased maternal age, multiple gestation, uterine tumors, and maybe the scar. That's why the placenta go and stick it over there. Abortion, CD, dilation and curettage, and myomectomy. It is basically painless. Abruptio placenta can be painless and can be painful, but in the scenario, they don't give you painless because they want you to make the diagnosis on the basis of the symptoms. So they're going to give you the painful. Remember that they are not going to give you anything out of the scope. They're not going to ask you something which is very, very complicated and you cannot make the diagnosis. They're going to give you the symptoms which is present on the daily basis. Any disease you are going to do or study, remember that you need to know the basics. If you are studying something complicated and you are missing basics, remember that you are doing wrong. You are going on the wrong side. Abruptio placenta is basically premature separation of the normal implanted placenta after 20-week gestational age, idiopathic 1 to 2% pregnancy. Then comes the risk factor, previous abruption, maternal hypertension or vascular disease, cigarette smoking, consumption of alcohol, cocaine, multiparity. So let's suppose if a woman is coming with a cocaine consumption and she's asking she's having a bleeding. Now you need to know that cocaine presents with the abruptio placenta. Since I already told you, the risk factors can give you the diagnosis. So you need to know this. Multiparity, maternal age, PPROM, and the rupture of the descended uterus, polyhydramnios, multiple gestation, anomaly, fibroids, trauma, and it is painful. So polyhydramnios can present as abruptio placenta. That's what I'm saying. You need to know the risk factors. They're giving you something, they give you very, very good hints in the scenario. Sometimes people say, oh, I couldn't get the diagnosis because you didn't need the you didn't know the risk factors. That's why you couldn't make up the diagnosis. They don't give you symptoms and signs. Sometimes they just give you the risk factors. So you need to know every single thing. That's what I'm preferably mentioning here. Then comes the placenta previa. Placenta previa is basically definition. You need to know as I already discussed, that implanted in the lower segment of the uterus, like in millimeter away or millimeter of the overlap. Then comes is basically clinical features. This is painless. Onset of the bleeding is 30 weeks after gestational age and depends on the degree of the previa. Physical exam, do not perform. Digital vaginal exam until rule out placenta previa. Sometimes they're giving you the bleeding and they're asking you what thing you will do. And sometimes people choose physical exam. And believe me, you are killing the patient. That is wrong. Do not perform digital vaginal exam until you rule out placenta previa. Anywhere, any bleeding that presents, you are doing vaginal exam, you are doing wrong. You are killing the patient. Uterus soft and non-tender, fetal part high and displaced, fetal heart rate, shock, anemia complications, prenatal mortality low, and then prematurity, hypoxia, malpresentation, PPROM. You need to know everything. This is important. Fetal blood loss from placenta if incised during cesarean delivery. Then comes maternal, maybe maternal will die because a lot of blood loss, hemorrhage, hypovolemic shock, anemia, acute renal failure, pituitary necrosis, basically Sheehan syndrome, placenta accreta, and anterior like uterine surgery and the placenta went all the way inside, hysterectomy, and do not perform vaginal exam until placenta previa has been ruled out by ultrasound. This is like a common statement. You need to know all those red flags that is present on the side of the Toronto notes. Investigation is basically transvaginal ultrasound you do, and then you rule out the placenta previa, and then is more accurate than the transvaginal. Which one I have to choose if there is given transabdominal and transvaginal? Obviously transvaginal, because this is more accurate. Then comes the spontaneous resolution. Transvaginal ultrasound should be repeated in T3 as maybe as soon as the baby is growing, and the placenta will move upwards. Then comes the management. Management is, this is the management you need to know for any of the bleeding. What is the management? Keep pregnancy intrauterine until the risk of the continuing pregnancy. Sometimes people do is delivery. You cannot do delivery right away, because if you can see that pregnancy inside is more better than outside, what are you going to do delivery, right? Stabilize the mother, give IV lines with hydration, O2-5 hypotensive patients, monitoring vitals, urine output, blood flow, blood work, fibrinogen, FTP type, and cross match. I will put the MCQs about it, not MCQs, actually CDM in the group, and I would love everyone to solve it, and we will discuss about it, okay? Then electronic fetal monitoring, ultrasound assessment when fetal and the maternal conditions permit, then fetal viability, gestational age, and the placental location. ROGAM, if the patient is Rh negative, ROGAM is given likely wise. Then comes the clear Betke test to determine the extent of the feto-maternal transfusion and the administer ROGAM at the adequate dose. Then at the less than 37, admit to the hospital, limit physical activity. So now, what is this? This is something they're asking about less than 37 weeks. What are you going to counsel the patient? This is the expectant management. This is basically counseling the patient that you don't have to do physical activity, no douches, no enema, no sexual contact, intercourse. So these are the things you are going to write on in counseling session, that you don't need to do this, don't do that, don't do this, don't do that. This is not something treatment. This is basically counseling, right? So you need to know this. And maybe you can consider corticosteroids and, fetal lung maturity. You might have to deliver it anytime. So delivery is mature or the hemorrhage indicating maternal or the fetal compromise. More than 37, delivery by CD. Then comes the placental abruption, which is the last topic of today. Partial and total placental detachment that is premature and caused by bleeding by the residual placental interface. More than 20 week it will present. Since it is mentioned here, this is more than 20 week, right? And here it was in 30-week gestational age, mean onset. So you need to know these weeks. Then the classification may be total versus partial, external, revealed, apparent, internal, concealed, occult, most are mixed. So it can present in any form. They will give you the general presentation. Like placental preparation is the most common cause of DIC in the pregnancy. Then it's basically presentation, 80% is painful. So they're not going to give you painless, right? Because 80% is painful. So they will give you something which is common. They're not going to ask you to go in the very detail and you have to rule out every single thing, because you are writing the paper. You are not going to investigate the patient right away. They are giving you something and you cannot assume, oh, this might be happening. This might be happening. No, what they are giving, this is something, what it is common. Vaginal bleeding, then uterine tenderness, contraction, hypertonus, pain onset, okay, pain onset constant and constant pain localized to the lower back and the uterus, shock, anemia, fetal distress, fetal demise, bloody amniotic fluid, and coagulopathic complications may be prenatal mortality, prematurity, intrauterine hypoxemia, and maybe maternal mortality. DIC is very common. Renal failure, hemorrhagic shock, pituitary necrosis, and amniotic fluid embolus. So it is common. This amniotic embolus, I have seen a couple of questions in uworld about this amniotic fluid embolus after this placental abruption and Sheehan syndrome. Then comes the clinical diagnosis. This is basically you don't have to do ultrasound. In Previa, you were doing ultrasound, but here you don't have to do ultrasound. She's coming with a lot of pain, have a lot of bleeding. She is basically placental abruption. This is not placenta previa. Okay, then what are you going to do? Stabilize, large bore IV with hydration, oxygen for hypertensive, vitals, urine output, blood work, blood loss, blood work, hematocrit, CBC, PTT, fibrinogen. You need to know what is the blood work you are going to do. And everything will be written in the each and every separate line. You cannot write down everything in one line. We will talk about this when we are doing CDM session. EFM, blood works, ROGAM, clear Betke test. And then we are going to give clear Betke test to assess for the use of the ROGAM, how much ROGAM is needed. Then abruption without the placenta, maternal compromise, less than 37. What are we going to use? Serial hematocrit to assess the concealed bleeding, deliver when the fetus is mature and when the hemorrhage dictates. More than 37, stabilize and deliver. Abruption with the fetal and the maternal compromise, restore blood loss and correct coagulation, defective presence.
مشال بس حسي بديك دواء كويس امشي.
No contraindication and no evidence of the fetal or the maternal distress. Cesarean delivery is the live fetus and the fetal or the maternal distress develops with the fluid and blood replacement. Labor fails to progress if the vaginal delivery. So this is the last topic of today.
كده يا علي انت كمان